Hello, everyone. A very good afternoon and welcome to the international webinar on protecting the healthcare workforce by infection prevention and control in COVID-19 pandemic, hosted by Government College of Nursing Kozhikode, Kerala. On behalf of Government College of Nursing Kozhikode, I would like to extend a warm welcome to all of you. We value your presence and the time you spend with us. Since 2019 December, a rapid outbreak of COVID-19 has become a public health emergency of international concern, which has contributed to an enormous adverse impact globally. The current status of COVID-19 has led us to accept the reality of living with COVID-19 and fight against it. Vaccine development and research into medical treatment for COVID-19 are underway, but are many months away. Meanwhile, the pressure on the global healthcare workforce continues to intensify. This pressure takes two forms. The first is the potentially overwhelming burden of illnesses that stresses health system capacity, and the second is the adverse effects on healthcare professionals, including the risk of infection. Evidence related to transmissibility and mortality inform the clinical community of the importance of vigilance, preparation, active management, and protection. At this context, Government College of Nursing Kozhikode is organizing an international webinar with an aim of alerting the healthcare professionals the need to protect self and their team members, protect their family members, and also to protect their patients by adopting infection prevention and control strategies. First and foremost, I would like to appreciate and acknowledge the people behind the screen in the successful conduct of this international webinar. Our chief organizer, Professor Ponnamma KM, Principal, Government College of Nursing. The coordinator of all the webinar series, Dr. Sridevi J, Associate Professor of this college. And the technical team headed by Mr. Anish Kumar K and Mr. Salim TK, assistant professors of this College of Nursing. Without their help, we could not have done this successfully. Today, we have 9 eminent personalities from different countries to talk about this concept. Before going to the session, I would like to welcome Professor Prasanna Kumari Y, former Joint Director Medical Education Nursing, Government of Kerala, and Patron Critical Care and Rehab Nurses Forum, CCRNF, who has kindly consented to inaugurate this webinar and also to be a panelist. Madam is joining us from UAE, and we have some technical difficulties, and Madam will be joining very soon. With pleasure, I welcome Professor Ponnamma KM, Principal, Government College of Nursing, the chief organizer of this webinar. Once again, I welcome all the participants and esteemed panelists who have joined us in the midst of their regular clinical, academic, and COVID-19 containment activities for the sessions. In addition to the Zoom, we are doing live streaming through YouTube, which reach thousands of healthcare professionals around the globe. Please watch the session, and if you have any questions or doubts, please type it in the question and answer portal, which is displayed on the screen. The link for the feedback form will be available in the chat box at the end of the session. Please fill and submit at the end of the webinar so that you will get an e-certificate which will be mailed to you within 7 days. Now, let us move on to the first session of the webinar. I have immense pleasure to invite Dr. Mini Pian, an eminent microbiologist who have been with us for a long time and has done a wonderful job in the containment of Nipah attack 2 years back, and also in the current COVID-19 pandemic. Madam works as an additional professor, Department of Microbiology, Government Medical College, Kozhikode, India. Madam will be presenting the first talk on protecting healthcare workforce in the control of COVID-19. On behalf of all the organizers, may I welcome you, ma'am, for the first session. Over to you, ma'am.
Yes, very good afternoon, all. I thank Purnama Madam for having given me this opportunity to be a speaker on this webinar. I also congratulate the team behind this. A very wonderful webinar. This is the major means of communication, or rather, a very important means of educating one and all. So now the COVID-19 pandemic, the topic is protecting healthcare workforce in the context of COVID-19. The microbes are the invisible invaders. In the context of COVID-19 pandemic, as you all know, this has become a real havoc of international concern, because these microbes are all very invisible, and we cannot imagine the problems, or rather the difficulties it has brought about in our daily chores. The total scenario of the world, or each and every person, has changed. So the invisible invaders are a real threat to the human mankind, where each one of the healthcare workers have to be in constant vigil. Right from December 9, 2019, we have been constantly in a great vigil to combat this infection. Prevention and control of any infectious disease is a major priority, and it is a part of patient safety. Now, initially, the healthcare workers were put on a great concern about the patient safety. Now, in this juncture, during this COVID-19 pandemic, it is more important that the healthcare workers are well protected and taken care of during their patient care activities. And this virus, the corona virus, COVID-19 virus, is a beta coronavirus. As you all know, it is an enveloped virus with a spherical RNA, size spherical, with a diameter 120 nanometer size. This virus has become the fifth pandemic, or this novel human coronavirus disease has become the fifth pandemic. It was first reported in Wuhan, China, which subsequently spread worldwide. Common mode of transmission, as you all know, it is the by droplet, and also more important, close contact. Also, another route of transmission is the aerosol. So the SARS or SARS-CoV, MERS-CoV, SARS-CoV-2, these are this virus that cause the severe acute respiratory syndrome. As Florence Nightingale has said, that she has said that very first requirement in a hospital is that it should do the sick no harm. In an hospital, when a person is admitted, he has to get cured of the disease. But when he lands up in another disease, that is by the hospital acquired infections, it is the healthcare workers that take care that no hospital acquired infections occur. And now it is not only the care of the sick, but also the care of the healthcare workers. So now about the pandemic, how this COVID-19 pandemic has become the fifth one. 1918, the Spanish flu, H1N1 influenza virus, then later Asian flu, that is H2N2 influenza A virus, occurred in 1957. 1968, Hong Kong flu, H3N2 influenza A virus. 2009, it is a pandemic flu, H1N1 influenza A virus. And this COVID-19 or coronavirus SARS-CoV-2 in 2019. Now 2020, we are battling to combat this. So a prime aim of the healthcare providers is to deliver quality service by using all healthcare facilities. Excuse me. The prime aim of the healthcare providers is to deliver quality service by all healthcare facilities. In COVID-19 pandemic, the healthcare worker in any capacity are at high risk of getting infected. So it is the healthcare worker who has to be taken care of more during this pandemic period. So there should be a guidance to protect our healthcare workers and patients from nosocomial transmission, and it should be of prime importance. So in order to battle these invisible invaders, the healthcare workers are at the front line. They are the frontline warriors during this challenging period. They are the frontline warriors if any outbreak occurs. They are exposed to hazards that put them to risk of infection with the pathogen of COVID-19. We have to look at the hazards that they are put when they care for the patients in a COVID-19 positive wards or the hospital isolation rooms. Hazards include long working hours. The working hours when they don this PPE in the isolation rooms or in the hospital wards, the infection or the hazards that they face are the psychological distress, and the fatigue they have to overcome, the occupational burnout. And when all this occurs, and there could be a decreased staff overburden. So these are the problems that are faced by the healthcare workers, and this has to be rectified by certain means. So now let's see the risk areas in teaching healthcare facilities. Ours is a teaching hospital, that is teaching institution, medical college. We work in the medical college institution. So we have the students, we have the healthcare staff. So what are the difficulties dealt while facing dealing with the patients? The procedures with increased risk of transmission. When they perform procedures, and proper use of personal protective equipment in designated areas. Also in intensive care units, in community transmission, also transportation of serious patients in isolation wards, and supply of food to the patients. In all these areas, the healthcare workers, be it a nursing staff, be it a medical personnel, a doctor, or a cleaning staff, whoever attends to the patient care, they are facing problems like in an isolated room when the duty hours are over, when a serious patient comes up, the difficulty in transporting them alone. So this has created a problem in many of the healthcare workers. So also supply to the food, how the food has to be supplied or how it reaches the patient care areas. These things are all very successfully dealt with our healthcare workers. And this is just a picture to show you the transportation of patients, uh, the healthcare workers in the personal protective equipments. The healthcare workers, they are not only caring but also battling. Why battling? Because when they care for the COVID-19 patients, they also face mental stress, physical exhaustion, like I said earlier, and the apprehension among healthcare workers that occurs because there is always or sometimes limited supply of personal protective equipments. Initially, there was a vigor or rather full brimming of energy in caring for the patients. Later on, when the cases started increasing, patients started increasing, there was a limited supply of personal protective equipment. And the quality of the personal protective equipment which is being supplied may not be of a good quality one, and this also causes apprehension among all. And the most important, in order to prevent the infection, which is most commonly, which is transmitted by the respiratory route, here face masks that are being supplied may not be of adequate number. The face mask that has to be worn or donned by the healthcare worker is suggested, that is the N95 mask, which will give the complete protection. And there is limited supply or the adequate supply of the face mask may not be sufficient because of the increase in number of the cases. The risk, the high risk, that is procedures, sorry, that's spelling mistake. Procedures with high risk, that is when a patient, when they have a close contact with a patient, a COVID-19 patient in the community without proper protective equipment. When they give care to the patient, that is without proper hand hygiene, or when they when they are giving care while doing procedures like aerosol generating procedure, the way they have to be in close contact with the patient, or during nebulization, or during NIV and nasogastric tube insertion, non-invasive techniques, also endotracheal tube insertion, and while during specimen collection, or when they have contact with the patient secretion. All these are the means where they come into contact with the patient in a close proximity. And also they are exposed to the laboratory while they collect the specimen, respiratory specimens from the infected patients. So these are the procedures where they have come into close contact with the patients. So in order to define the risk or put them into safer positions, we have the quarantine committee, we have the surgical screening committee, also the institutional quarantine facility, and the diagnostic test, which are point of care test. The healthcare workers are also posted in the first line treatment center. We have the first line treatment center when there's enormous increase in the number of patients. The first line treatment center, Corona CFLTC, which we have recognized, which we have identified nearby areas, say in hostels, etc., a large where there is large number of students were accommodated. These hostels were being transformed into first line treatment center, and their designated healthcare workers are placed in order to care for the patients. And all the healthcare workers are being trained regularly in order to overcome the difficulties they face in such COVID positive areas. The quarantine committee, which is special help for the healthcare workers when a healthcare worker reports exposure, that is he or she has to report it to the nodal officer or the superintendent or the principal. In such case, quarantine is based on the risk category. It depends on the level of exposure of the healthcare worker, how, and they are categorized accordingly, whether they belong to the high risk or low risk. According to that, they are put into quarantine. The high risk category is That is, when a person or any healthcare worker does not have the recommended personal protective equipment, or whenever there is a possible breach of personal protective equipment, that is without a mask, or they do not have a face shield, or without proper goggles that correctly fit their eyes, or where they have performed aerosol generating procedures, and when they have a face-to-face contact with the COVID-19 case, that is within a distance of 1 meter, when they're close proximity, and when they are in contact, say, for more than 15 minutes time, then they are said to be in close contact with the COVID-19 positive case. Also, having accidental exposure to body fluids. In such cases, the healthcare worker are said to be of belonging to high risk group. And what is done to the high risk group individuals, healthcare personnel? The incident COVID-19 exposure to healthcare providers, if a positive case is reported, I told earlier that they reported to the nodal officer, the particular HOD in charge, and the primary contact list is prepared. If a person is said to be COVID positive and a person passes nearby, it does not show that he is of healthcare, he is under high risk. The high risk person, and when the contact list is prepared, that is a person who has undergone HE, who was in close contact with the COVID positive patient, all the list is prepared, whether it is the doctor or the nurse or the clinic staff, whoever has had very close contact with the COVID positive patients, the high risk individuals are placed for 14 days quarantine. That is, there is institutional quarantine which is arranged, and the diagnostic test RT-PCR is done on 8 to 10 days, whether after 7 days a test is done. If the test turns out to be negative, complete quarantine 14 days and then can join duty. In between, monitor for the development of symptoms, whether any cough, fever, any breathlessness occurs. The symptoms can be monitored. The low risk category, that is who have not had that contact, close contact, or if there is no breach in PPE, low risk contact individuals can be they can continue to be on duty, and there is no quarantine for that. That is why the contact list is prepared. And also they have to self-monitor for the symptoms till 14 days after last contact and report if any symptom occur. The symptoms have to be monitored when they are on 14 days. Now, what are the precautions to be followed to minimize the risk of transmission? By now, all healthcare workers, we have been working, or our healthcare providers, they have been working right from the COVID-19 cases are diagnosed. It is since 5 to 6 months now, right from January, March, they have been working. And now all our healthcare workers are very much educated about the precautions. That is, the standard precautions they follow. And while following the standard precautions, we aim at the epidemiological triangle. That is, the first is the organism, microorganism. Second is the host. Third is the environment. So, keeping all the three epidemiological triangles in mind, the standard precautions are followed. The standard precautions, as you all know, it is the work practices that are followed by any healthcare worker, that is to minimize the transmission of infection. So in it, the first and foremost is the proper hand hygiene protocol. Hand hygiene protocol. Now this hand hygiene is the cornerstone of any measures of preventing transmission of infection. And now it has become a routine practice in our daily life. And everywhere it is being practiced, hand hygiene. Now all of us are using sanitizers, washing hands. So the first and foremost is the proper hand hygiene protocol. Second is the proper use of personal protective equipment. The term should be proper use. It is proper use of personal protective equipment, and to follow the correct donning and doffing protocol. When they follow the correct donning and doffing protocol, the measures like each component of the PPE, when to don each component first, that that has to be taken care of. And the most important is the N95 mask. We have the supply of 3-layer surgical mask, also the other mask also, and the mask with expirators. Of course, the valve expirators masks are not advised. It is not advised. It is considered to be hazardous in a hospital setting. So now we have advised not to use the expirator or the mask with valve. In COVID positive areas, only N95 masks are being supplied or advised to be used in the COVID positive areas. So, and the mask it should be a snugly fit one. It should not let the air flow. It should be done. That is, a fit test has to be done when the N95 mask is worn. So, in a COVID positive area, maintain minimum close contact. That is, avoid close contact. It should not be within 1 meter. A distance should be maintained, say for more than and not more than 15 minutes. The contact time should be very minimum, and the number of people there should be very minimum, and the time also where you have contact with the patient is also very, very minimum. But with caring the patients, okay. And the disposal of personal protective equipment also is to be done meticulously. Hand hygiene, after all the doffing of the PPE, a hand hygiene is a must, and a shower. We have arranged in our medical college or in our institution a proper isolation ward is set up, and we are looking for more and more facilities now, and shower, everything, isolated area, everything is being, we are making it more and more effective, and also effective environmental cleaning. Now there is no talk, or there is no what do you call, infection control procedures without mentioning of this great person, Ignaz Semmelweis. Ignaz Semmelweis was a Hungarian physician. So it is every woman who was given birth in the last century owes a huge debt of gratitude to Ignaz Semmelweis. This is because it was this person. I would like to pay gratitude to this great Hungarian physician, because it was Ignaz Semmelweis long 150 years ago. It was this person who has introduced the technique of, or the importance of, hand hygiene in caring for a patient in order to prevent transmission of infection. How important hand hygiene is. That is because you all must be knowing about the story, that is the medical personnel, they used to attend deliveries following, they used to attend autopsy following deliveries. So he found that there was a cadaverous particle which was the causative agent for the puerperal sepsis. That was the women who gave birth, they had undergone. So, and one of his friend, a pathologist, also got injured with a scalpel and he developed sepsis and died. So this made him think about it, that hand hygiene would prevent this puerperal sepsis or the sepsis in any person. So so it was he who advised that any medical personnel should do hand washing and attend any patients. So later on, he was put into mental asylum, and only after his death that everyone followed the hand hygiene technique, and this could bring dramatic reduction in the death rate of women. That is why women who have given birth in the last century who owes a huge debt of gratitude to Ignaz Semmelweis. So it was Ignaz Semmelweis who introduced the importance of hand hygiene. So initially, I told you the point of care test that is done for diagnosing COVID-19. Some of the tests that is being done now, that is a molecular test, nucleic acid amplification test, RT-PCR, which is of highest sensitivity, and the gold standard, and specificity. This detects the presence of infection. This molecular test, this targets the E gene, that is the envelope gene, also the RD-RP gene of SARS-CoV. The another molecular test, that is the TrueNat. TrueNat is a chip-based point-of-care test. Here, the E gene is detected in the first level of screening. RDRP gene for confirmation. Here, in TrueNat, all negatives are considered to be true negative. We have the another test, that is a CBNAT, or the expert gene expert, that's for SARS-CoV-2. Here, E gene and N gene that is detected for screening and confirmatory. This will take say 2 hours for the test to be done. So these tests are being done in our college, RT-PCR, TrueNat. So the sample that is taken is the nasopharyngeal swab, and the person collecting the swab should be in a personal protective equipment, proper personal protective equipment. We have now, in case surgical mask is not, or in case N95 mask is not available, sometimes a three-ply mask or the hood can be used for collecting this nasopharyngeal swab. Also, oropharyngeal swab is also collected, and this is put in a VTM and detection is done. The antigen test, this second one, antigen test, this detects the presence of viral proteins. This is done in case of primary contacts. ICMR has advised this test to be done in the containment zones. This is used for diagnosis, and this test is high specific. This has got high specificity, say about 100%. And the test positives are true positives. But the antibody test is done for the seroprevalence study, that is not used for diagnosis. This is after a patient has had infection, usually after say when the patient must have had have developed antibodies, that is say after 7 to 14 days. So this is a rapid test done, and here the sample that is taken is the serum. So these are the tests available for detecting the coronavirus, COVID-19. In order to help energize the healthcare workers, training sessions and awareness class, telemedicine, like now we are doing it here. Very thankful to Purnama Madam and her team for conducting this team. We are able to make aware of all the possible techniques that we have to save our healthcare providers. Also, now our healthcare team or the infection control team in our institution is very vigilant in training many of the groups, that is the cleaning staff, the X-ray technicians, the pharmacists, all the healthcare personnel, the security staff, everywhere. The training is going on and on. It is daily procedure where we have the infection control nurse and the infection control team going on meticulously, hoping to combat this infection very soon. So the rationalized human and material resources. Material resources and human resources, that is proper use of the materials wherever they're required. Now, in order to see, for example, in the reporting sessions, etc., or in COVID caring places, COVID caring centers, the recruited person should be minimum, and or the right person should be allocated in the right place, or rather properly trained personnel in order to care for the patients. Also, the material resources, it should be used meticulously. Only the required materials should be used, not in excess, or the proper use. Also, prioritizing healthcare workers for SARS-CoV testing. And if any healthcare personnel, they turn to have symptoms in between, prioritization of testing should be done for healthcare workers, because they have to go on for work again. If any healthcare workers are from the confinement zone, they are asked to come for work again, because they are to care for the patients in need. And also reduce patient contact, thus minimizes the infection risk. And always the healthcare workers who are involved in such scenario or the difficult situation, they should be supported with proper personal protective equipments, the proper kind of mask overall, proper gloves, proper quality gloves, and proper mask. And also staff motivation should be there. Sometimes there will be energy draining of our healthcare workers in between. Motivated motivation have to be provided for them, like risk allowances and compensation. Hope planning or hope such allowances will be recovered or will be got to the healthcare workers in future. Let's hope all best. Now, these are the training classes being given earlier before social distancing and all. And now the training sessions are being done with proper social distancing, also in webinars and by conducting uh, Zoom conferences, etc. So, ensure all necessary preventive measures are taken to minimize occupational health risk. Preventive measures ensure all, excuse me, the preventive measures ensure all necessary preventive measures that is taken to minimize occupational health risk. Important information and training on the infection prevention and control should be given to all the healthcare workers regarding the proper use and disposal of PP. There is still the lacuna between healthcare workers. Even today, we have got that a certain group of healthcare personnel have not got the training. So all the loopholes have to be, all the lacuna has to be filled, and provide adequate infection control, infection prevention and control supplies. I mean, talks and supplies, PPE supplies to healthcare staff or other staff, those who are caring for the patients or the suspected unconfirmed COVID-19 patients. Also, get familiarized with the technical updates on COVID-19. What are the updates on COVID-19? All of them have to be made clear. Or what are the quarantine measures taken, or what are the measures they have to follow in order to prevent themselves from infection, and also provide with appropriate tools to assess in the triage area, also the tests to be done, and always the information have to be shared among all the healthcare staff, and it should be provided with appropriate security measures for personal safety. So we are not only caring for the personal safety, the health of the community, health of the family, and health of the every person whom we come into contact with, are all made aware, educate all the people. So the solace or the comfort that has to be given to the healthcare workers, that is, they should be provided with a safe environment to be provided. That is, in case any breach in the PP occurs or if they have been exposed to risk, there should be a proper caring person or somebody to listen to their problems in case they report any incidents of exposure to any health authorities, to higher authorities. The higher authorities have to make proper amendment or proper implementation to rectify their defects or the accidents that has occurred as exposure that they have come across. Also, advise on self-assessment of symptoms reporting and stay away from the work area when they are ill. They should be given proper information regarding the symptoms what they encounter with. Also, maintain appropriate working hours with in between breaks. They should not be compelled to work hours together. There should be uh, immediate another person notified in case the person identified in an area gets sick. So there should be proper maintaining working hours for them. There should be enough break given for the healthcare workers. This is in order to make them boost their morale. Also provide access to counseling services in case of mental distress. Many of our health colleagues, they they not complain, they often um, suggest that there are friends with mental distress. They are not able to cope up with the increased number of cases. In such cases, counseling services, we have counseling services with psychiatry department, and they give proper guidance regarding how to go about caring for the patients in case there is a increase in number of the pandemic occurring. Follow the established COVID-19 safety institution guidelines. We have formed institution guidelines regarding the infection control activities, and which is being circulated among the institution. We have the dental colleges, we have the nursing college, we have the pharmacy college, we have the institution of maternal and child care. So all the institutions, we have the institution guidelines set up, and these guidelines have to be followed, and help should be extended to all the healthcare workers who are in need. So the most important, when we regularly come into contact with any person or any COVID-19 patients, that is, there should not be three things, very important three things. No face-to-face contact. That means there should not be close contact. Of course, there are possibilities where they have to come into close contact, but minimize face-to-face contact, and proper use of N95 mask. Hand hygiene, of course, because this has become a routine, it is always mentioned. Hand hygiene, proper hand hygiene. Then N95 mask with, because this is a respiratory pathogen, and the mask, proper usage of mask will take care of most of the infections, followed by infections by respiration. One word about the transmission, that is transmission based precaution. We know that the airborne precaution and the airborne and droplet contact precaution. Airborne, the droplet size of the airborne precaution, that is airborne infections, the droplet size is less than, say, 5 micron, because the droplets are so small that because it is so small, that's why they travel a long distance in case of aerosols, that is airborne infections. But in droplet infection, the size of the particle is more than 5 microns. The particle size drops off, that is, say, within 1 meter. That is why the social distancing, the maintained distancing, that is why the aspect of distancing, maintain distance among each individual. Also, when in an area with COVID positive patients, maintain cross ventilation in a room, or in suspected cases, there should be cross ventilation in a room. Also, air purifier, there should be air purifiers. We have accommodated, or we have established the negative pressure ventilation rooms, etc., for the COVID positive patients. So these are the important three things, and hope we care for the all individuals, all patients, or the healthcare workers, patients and healthcare workers safety with good vigil. And thank you all. Let us hope for this pandemic to come to a standstill. Let it all go away. Thank you all. Thank you so much.
Thank you, Dr. Mini PN, Additional Professor, Department of Microbiology, for a wonderful session in which she has included the most practical aspects. We also appreciate for being the great team player during this pandemic. There are a few questions to Madam. We will come back within a short time. Without much delay, let us go to the second session of this international webinar, disinfection of patient gadgets in COVID-19, especially in all patient care setting. We are delighted to have Mrs. Jane Paul, the infection control nurse coordinator of Government Medical College Hospital, Kozhikode. She also takes the additional responsibility of the deputy coordinator of clinical nursing education unit, which is well functioning in our institution. On behalf of the organizers, may I extend a warm welcome to Mrs. Jane Paul. Over to you, ma'am.
Good afternoon to all. When we look into the current scenario, many of the healthcare personnel are getting infected around the globe. As an ICN, it's my responsibility to protect all healthcare workers of the hospital from getting the infection. We need to concentrate more on the disinfection methods of patient care gadgets in order to protect both staff and patients. Patient care gadgets. Healthcare gadgets are the sensor-based devices that are able to track and alert about healthcare issues. The modern healthcare gadgets are mostly powered by mobile apps, which you can easily install on your smartphones. For example, ventilators, HFNC, NIV machines. Why to worry about patient care gadgets? Works closely with patients and healthcare workers. Highly exposed to patients' secretions. Contact timing very high. Needs specific care while handling. Disinfection need to be more specific and focused. Common source of cross-infection in healthcare settings. So let us look through the parts of a ventilator. First one, you can see support arm, inspiratory port with filter, active humidifier, inspiratory line with water trap, Y-piece, expiratory line with water trap, expiratory port, flexible connector, proximal flow pressure sensor, nebulizer. Let us go through the first ventilator, Dragon Sabina 300 Evita. So whatever thing we are going cleaning for the ventilator, we have to use the proper PPE. First, cleaning. Cleaning should be done before disinfection. If secretions present, clean it with soap solution and running water. Don't use brush or hard objects for cleaning. Next, disinfection. We have to wipe with 70% isopropyl alcohol or 2% chlorhexidine solution. The display, be careful. Cloth dipped in 70% isopropyl alcohol solution or spirit solution and dried completely should be used to clean the display. Do only if needed, as cleaning may damage the display if not done properly. Expiratory valve. You can see the expiratory valve. This you can autoclave 121 degrees Celsius for 20 minutes or dip inside of a solution for 15 minutes. Next, the flow sensor. Clean with the soap solution. You have to dip in clean soap solution. Next, dip inside a soap solution for 10 minutes. Wash with distilled water, then dry. Next, you can see the packet servo I, also the servo S. You can cleaning you can done. The cleaning procedure, you have to use the PP also. First, cleaning should be done before disinfection. If secretions present, clean it with soap solution or running water. Don't use brush or hard objects for cleaning. Disinfection. Surface, wipe the surface with 70% isopropyl alcohol or 2% chlorhexidine solution or 0.1% hypochlorite solution. Expiratory cassette. Cleaning procedure same as usual, but disinfectant used must be side away for 15 minutes. Cleaning procedure. First, you have to remove the expiratory cassette, run the water for cleaning through the cassette. Fill the disinfectant sides of it to the cassette, close both ends, and keep it for 10 to 15 minutes. Remove the disinfectant and run distilled water through the cassette. Ensure water is not poured on the cassette. Dry the cassette for 24 hours, keeping it at 45-degree angle. This is to keep all the water from inside the cassette. Cover after disinfection. Label the date and time of disinfection. Use only after 72 hours. You can see the next ventilator, Mindray SP300. Mindray SP300. Please ensure that alcohol or water not getting inside the machine. Surface, you can wipe the surface with 70% isopropyl alcohol or 2% chlorhexidine solution or 0.1% hypochlorite solution. Display, be careful. Cloth dipped in 70% isopropyl alcohol solution or spirit solution and dried completely. You can see the inspiratory flow sensor and valve. This you can disinfect Cytosope for half an hour, including flow sensor. ET also can do 45-degree Celsius cold cycle. Expiratory flow sensor and valve. Clean it with running water before following disinfection protocol. Puritin Bennett BB 840. This disinfection surface, wipe the surface with 70% isopropyl alcohol or 2% chlorhexidine solution or 0.1% hypochlorite solution. Display also, be careful. Cloth dipped in 70% isopropyl alcohol solution or spirit solution and dried completely. Expiratory filter, that is you can do 131 degrees Celsius for 20 minutes. Inspiratory filter 121 degrees Celsius for 30 minutes. Air liquid, example extended ventilators, disinfection. Please ensure that alcohol or water not getting inside the machine. Surface cleaning, wipe the surface with 70% isopropyl alcohol. Display, be careful. Cloth dipped in 70% isopropyl alcohol solution or spirit solution and dried completely. Should be used to clean the display. Expiratory valve, autoclave 121 degrees Celsius for 20 minutes. Not Sidus, it is not recommended in air liquid. Sensor only autoclave. Now you can see the high flow nasal cannula. This therapy is an oxygen supply system capable of delivering up to 100% humidified and heated oxygen at a flow rate of up to 60 liters per minute. How can you clean? You can see the parts. First, dispose all patient circuit tubers that you have to discard. It's all disposable. And remove all discard humidifier chamber. Connect the disinfection tube you can connect. Also switch on the machine. Disinfection starts. Then for 55 minutes, never interrupt the power supply during disinfection. Other medical equipments, monitors, wipe the monitor surface and the accessories. Example, ECG cable, SpO2 probe, etc. with 70% isopropyl alcohol. Display, be careful. Cloth dipped in 70% isopropyl alcohol solution or spirit solution and dried. Completely should be used to clean the display. All other critical equipments, wipe with cloth dipped and dried in 70% isopropyl alcohol solution. Thank you. Thank you. I am very thankful to Professor K.M. K.M. Panama, Principal College of Nursing, and Professor Dr. Sridevi, Moderator Dr. Sajid Kumar, and all other faculties and PG nurses for providing me this platform and being connected all time with us to support us in the fight of COVID-19. Thank you, one and all.
Thank you very much, Mrs. Jane Paul, the Infection Control Nurse Coordinator. She's always a hardworking healthcare professional who wishes to be always behind the screen. But we wish such great warriors to come forefront and share their valuable experiences with us. Now we have a few relevant questions in the Q&A portal. Wish to have a look at a few of them. The first one is the timing needed for each test results and how often the testing for healthcare professionals should be done. An N95 mask needed for patients. So such questions are there. And PPE, whether it is needed for cleaners in doffing room. May I request now Dr. Mini Pian and Madam Jane Paul to discuss this.
The questions that is, what is the timing needed for the results of each test? I said earlier, we have the RT-PCR test. RT-PCR, the test results will say come time taken is say about 5 to 8 hours. And CB-NAT, it will take up to 2 hours. The TrueNAT, it will take up to say 1.5 hours. And the antigen test, 30 minutes. Antibody, 15 to 30 minutes. That's all. So this is the time taken for testing. And the other factors also depend, like the reaching of the sample and processing of the sample, etc. for CB-NAT and RT-PCR, etc. So the next question is, how often testing is done for healthcare workers? Testing done for healthcare workers, that is based on the exposure, how often they are exposed. In case if a healthcare worker is exposed, testing is done, that is in order to define the quarantine period, testing is done. That is taking the contact list of the each healthcare workers, and depending on that, the tests are done. Okay. What's the other question? PPs. The other question is N95 mask needed for patient. The patients need not have N95 mask. The healthcare providers need to have the N95 mask because it is the healthcare worker who are more in contact with the positive patients. So that is the okay. What's the next question? PP needed for cleaning in doffing room. Definitely. PP is needed. Personal protective equipment is needed for the cleaning staff. PP needed for cleaners in doffing room. Yes, definitely, because doffing room is the room which is considered or is the contaminated area, and the person definitely has to be protected, which is the protective gear, that is the PP. Definitely needed. Okay. Okay. Thank you. Thank you so much.
We are excited to see the attendance in the Zoom as well as in the YouTube streaming, and also very happy to see the QA portal. There are some relevant questions asked. We will come back to the questions after a while. The third session of the webinar is on handling of dead bodies in COVID-19. It is not only the mass casualty management, mass fatality management also need to be taken care now. We have an eminent resource person in this area, Mrs. Jisha Varghese, who is the Chief Coordinator of Clinical Nursing Education Unit, Government Medical College Hospital, Kottayam. On behalf of the organizers, we extend a warm welcome to Mrs. Jisha Varghese. Over to you. I'm sure you will share some of your experiences that has happened in your town in the last few days also. Over to you, ma'am.
Hi all. Thank you, the organizers, for giving me such a platform. And in the previous sessions, Dr. Mini and Mrs. Jane Paul have beautifully explained regarding which are the precautions to be taken by the healthcare workers while handling a COVID positive patient. But here, I'm interested to speak on the precautions to be taken while handling the dead bodies of a COVID victim. As you all know, in our area also, the day-by-day cases of COVID-19 are increasing, and there are deaths are also increasing, and many are frightened about how to handle the dead body. Especially the public has concerns regarding whether the dead body will remain infectious or there will be any problem while handling the dead body or disposing the dead body in the areas. So the Government of India, the Health and Family Welfare Department, the Government of India has clear-cut guidelines regarding how to handle the dead body by the healthcare workers and during cremation or burial. And as it says, that if you observe strictly or if you adhere strictly to the standard precaution, there will not be an additional risk for the patients, for the relatives or the healthcare workers who are handling the dead body. So the main important thing is that we have to disseminate the knowledge and we have to give training for all who are involved in handling the dead body. And this include training of the staffs in the isolation ward, training of the person who will be carrying the body into the mortuary staff, persons in the ambulance, then staffs in the crematorium or the burial ground, like that. So I wish to explain the IPC guidelines for the dead body management in different areas. First of all, let me explain how we have to handle the body in the isolation room. That is, after the death has been declared, if whoever is going to handle the body, that usually a nurse will be there and there will be a helping person who will be assisting with the giving the death care. So they have to perform the hand hygiene at the first, and we have to ensure the proper use of personal protective equipments. And in this personal protective equipment, that should include a complete coverall, a head cover, then the face N95 mask, Google Surface Shield, double gloving, then and also plastic apron in order to prevent the water exposure or splash exposure to the PP. That nothing is causing injuries to us, and we can start handling the body. We have to handle the body very carefully and very gently so that nothing is injurious can happen. Then all tubes and drains and catheters of the dead body should be removed. While removing the tubes, drains, and catheters, we should be very careful to prevent the splashing. The splashing to our PPE, even though that is, we have PPE, there is chances of contamination or contracting the disease on doffing PPE. So any puncture holes or wounds that may be resulting from removal of the tubes or drains or catheters, that should be disinfected with 1% hypochlorite solution, and that should be dressed with impermeable material so that no oozing is there from that site again. Then we have to plug or deeply plug the nasal and oral orifices with the cotton, and this is to prevent the leakage of body fluids later when we are handling the body. Then after all these things, we can just tidy up the body of the patient, tidy up the dead body, and we can remove the excess linen or soiled linen, and that should be disposed into a biohazard bag. And after that, we can keep the body into a waterproof plastic bag that is known as body bag. That is, we can wrap the body in a cloth or any bedspread or something, and we can keep the body in the body bag. And after keeping the body in the body bag, we can close the bag. And here we have to instruct the healthcare workers to change the gloves which they are already used for carrying the body. That is, they have to keep the outer surface of the body bag maximally clean so that no risk is there. So the exterior of the body bag should be decontaminated with 1% hypochlorite solution, and this body bag can be wrapped in a sheet again, either a mortuary sheet or a sheet which is being provided. Then after all these things, we can give the body, either can be handed over to the relatives or taken to the mortuary. If we are handing it over to the relatives, we have to inform the local health authority so that they can arrange for infection control practices during burial or cremation. Then in the same room, in the isolation room, after transferring the body, all used linen or soiled linen should be handled with standard precaution, and that should be put in biohazard bag if you are not reusing it. If you are using it, we have to dip it in 0.5% bleach solution and have to allow a contact time of 20 minutes, and then only wash with soap and water. Better to dispose it in a biohazard bag. And after disposing the soil linen in the biohazard bag, the exterior of the bag should be decontaminated again with 1% bleach solution. Here in our institution and in our setup in Kerala, we are double bagging in order to prevent the exposure of the secretions into the outside area. Then after performing all these things, we can remove the personnel who are involved in this, giving that care to this, the body, can remove the personal protective equipment and perform hand hygiene. They should be strictly instructed to be careful while doffing, because exterior of the personal protective equipment, especially the coverall, will be more contagious, can cause infection to the person during the time of doffing. Then the patient care equipments, everything, all equipments in the room should be cleaned thoroughly, and if possible should be autoclaved or decontaminated with disinfectant solution, which is as per the manufacturer's instruction. Then all surfaces in the isolation area, that is floors, butt, railing, side tables, IV stand, etc., should be wiped with 1% sodium hypochlorite solution. And it is better to clean that area only after 30 to 45 minutes of shifting the patient, so that all aerosols that is dispensed in the area is settled by that time. And we have to ensure that all the staff, or the cleaning staff, whoever is involved in cleaning and disinfection in that area, should be on complete personal protective equipments. Then a word about handling the dead body in the mortuary. If you are shifting the body from the ward to the mortuary, that we will be shifting the body in a body bag. The exterior of the body bag has already been decontaminated with 1% sodium hypochlorite solution. So the mortuary staff will not be having much additional risk. So it is enough for the mortuary staffs handling the body to observe the standard precaution of using gloves and mask only. And the transport trolley should be properly disinfected with 1% hypochlorite solution after transferring the body. And dead bodies usually stored in the cold chambers maintained at 4 degrees centigrade. Then after removal of the body from the cold chamber, the chamber door, handles, and the floor should be cleaned well with sodium hypochlorite 1% solution. Then embalming. Usually in our country, this is not a culture of embalming. And embalming of the dead body is anyway not at all allowed in case of COVID-19 deaths. Regarding autopsy, ideally, as per the guidelines of dead body management of COVID-19, autopsy should be avoided. But if in case of unavoidable circumstances, that means if it is a medical legal case or the cause of death is not at all sure, the autopsy may have to be conducted. If autopsy is to be performed for special reason, the following precautions to be maintained in the autopsy room. It is better to have a negative pressure autopsy room in that area. Then the team who are involved in this body handling or autopsy should be well trained in infection control practices. The number of forensics experts and the support staff in the autopsy room should be limited. And all team should use full component of PPE, that is coveralls, head cover, shoe cover, N95 mask, goggles, face shield, because they are handling with viscera too. Then during this autopsy, we have to be very cautious to prevent the prick injuries. As per the guidelines, it is advised to use round-ended scissors for this autopsy, and also heavy-duty blades with blunt ends are used for cutting that skin opening like that. Then whenever we are opening these cavities, only one body cavity should be accessed at a time. That is a guideline. Then again, we have to be very conscious to prevent the splashes. It should be very reduce aerosol generation to the lungs of the COVID patient or dead body can be infectious. So especially there should be very, very careful while handling a lung tissue of the dead person. And also while sewing the skull, it is advisable to use an oscillator sew with suction extraction of the bone aerosol so that there is no aerosol exposure into that area. And after the procedure of autopsy, the body should again be disinfected with 1% sodium hypochlorite solution and can be kept in a body bag. The exterior of the bag should again be decontaminated with sodium hypochlorite solution. We can wrap the body bag in a mortuary sheet or a sheet provided by the relatives, and we can hand it over to the relatives. The autopsy table and the autopsy room should be disinfected as per the standard protocol in that institution. Then regarding transportation, the personnel handling the body may follow standard precaution. As per the government guideline, it is enough to use a surgical mask and gloves while handling the body in a body bag, which is properly secured without leak. But actually, because of the increasing fear of the staffs and also the public, we are insisting on use of complete personal protective equipment by all persons who are handling the body, even though it is in a body bag. The vehicle, after transfer of the body to the cremation or burial ground, can be decontaminated with 1% sodium hypochlorite. Then at the crematorium or the burial ground, the staff should practice standard precautions of hand hygiene, use of mask and gloves. I already said here we are extending into complete use of personal protective equipments. Then if the relatives want to see the body, just we can allow them to see the body by unzipping the face end of the body bag only, but we should never allow the relatives to touch on the body or the body bag. And if they want to perform the religious ritual like reading from the religious scripts or sprinkling holy water, and at the last rite, touching of the body can be allowed. Then bathing, kissing, hugging, etc. of the dead body should not be allowed. And if they want to collect the ash for further last rites, they could be allowed to collect the ash because it doesn't possess any additional risk. And at the crematorium or the burial ground, large gatherings should be avoided because many of the persons who are attending this cremation or the burial may be close contact of the victim, and there's the chance of spreading the disease. And also that should be insisted, all persons who are handling who are attending the cremation or burial should perform hand hygiene and to perform very good personal hygiene so that there is no risk of transmission. These are the major guidelines regarding the management of dead body by the government, Health and Family Welfare Department, Government of India. As in our brochure says, coronavirus is not a joke. Everybody should be educated regarding the chances of transmission, and we should be equipped well to fight against this coronavirus. Thank you once again for the team Coricor for giving me a chance in this webinar. Thank you.
Thank you, Mrs. Jisha Varghese. We are so happy to acknowledge that Mrs. Jisha is our alumni. We have esteemed panelists from different parts of the globe to present the perspectives from their country and region. We are so excited to see one of our alumni from Government College of Nursing, Trivandrum, who has more than 10 years of experience in Australia. May I now welcome Mrs. Chitra Ebi, RN MSN, Clinical Nurse, Acute Surgical Unit, Royal Perth Hospital, EMHS, Australia. She has done her master's in medical surgical nursing, and she has so many other certifications in her credit. May I now request you to present the perspectives from Australia and your region.
Hello.
Yes, ma'am, audible.
Okay, thank you. Good afternoon, all. I hope you are all well. This is Chitra. I'm a clinical nurse at one of the tertiary hospitals in Western Australia. I'll share my screen now. Hello. I'm privileged to be here to sit along with President Omari Madam and other esteemed panelists from around the world. And I express my gratitude to beloved Panama Madam for giving me this opportunity to present this topic here. I was a bit nervous when I was asked to do this presentation because of many reasons. One, I'm not an expert in this field, and I didn't have the authentic scientific knowledge to do this presentation. And also, I must say, I do not have any personal experience in looking after COVID positive patient, because we've been lucky here in Australia, and especially Western Australia, without any community transmission, and we've been safe until this time. Acknowledgement of country. We acknowledge the traditional custodians of the land in which we live and recognize their continuing connection to land, water, and community. We pay our respects to elders past, present, and emerging. Because of the strict social media policy of my organization, I have to display this disclaimer. The material and information contained in this presentation are general information only, and I'm not an authorized representative of this organization in which I work. So any suggestions and opinions included are personal only. So welcome all again. As I said, I'm not an expert in this field, but I just wanted to do this presentation based on what my knowledge is and what my experiences are about the measures we developed here in Australia in order to protect our healthcare workforce during this pandemic. And also I want to stick with, make it simple and stick to the point in order to achieve these following objectives. So I believe at the end of the presentation, the participants will be able to identify the need for protecting healthcare workforce, understand the COVID-19 response at various levels of administration in Australia, gain an insight into a different cultural work environment, and promote a culture of safety and quality in the workplace, and also will be able to apply some skills in empowering our colleagues at an individual level. So let's look at the first objective. What's the need to protect our healthcare workforce? So on 12th of March, WHO declared COVID-19 as a global pandemic and urged all national leaders to be prepared. And healthcare workforce, we are in the front line of any event of disease outbreak, and we are at risk on two fronts: inside the workplace and outside the workplace, that's in the community. Recent studies have shown that more healthcare people get infected outside the workplace, that's in the community, because of the spread or transmission in the community. And also there is a global shortage of healthcare workforce, and with the emergence of COVID-19 has added extra pressure to the strain. And as we all know, it's more feasible to protect our existing workforce rather than replacing the lost ones. We are all valuable members of the healthcare workforce. How can we achieve this? So as I said, with the urge from the World Health Organization, we have seen a huge response from national leaders, and we saw the same response in Australia as well. Before we go into details, let's have an overview of COVID-19 in Australia. Australia, with a total population of 25.499 million, we have seen total cases of 14,935, with active cases 4,714, with a total death of 161. The state in which I live, we have seen a total with a population of 2.7 million. We have seen total cases of 659, with active cases of 3, which are all in hotel quarantine, and total death of 9. So looking at the numbers, we can see that we did really well. We were able to flatten the curve quite early, and we were able to keep it flattened until we have just seen the second wave in some states like Victoria and New South Wales. So look at the COVID response in Australia. We have seen the response in national level, at state level, community level, organizational level, and at unit level, and also in individual level. So response at the national level. On 20th of March, our borders were closed. 21st of March, social distancing rules were imposed. And 25th of March, all Australians, citizens and permanent residents were forbidden from leaving Australia. PM also announced several stimulus packages to help the community survive, because only essential workers were allowed to work. Government urged public to protect others and stop the spread by staying home and maintaining social distancing rules. Also, RAPEX body, Nurses and Midwives Council of Australia, prepared a sub-registry of non-practicing professionals in order to backfill any deficits. We've seen huge response at the state level. On the 15th of March, government of WA declared state of emergency and a public health emergency. On 24th of March, state borders were closed, and 1st of April, intrastate travel restrictions were imposed. That is to limit the movements within the state, between the regions, in order to protect our most vulnerable population, that's our Indigenous population. And also from 5th of April, all arrivals are quarantined in city hotels for 14 days. Until date, that's continuing. And at the Department of Health level, that's our apex body who gives us all guidelines on how to contain any pandemic like this. So we have designed some suitable hospitals as COVID-specific ones. We have cancelled all elective surgeries except category 1 to free up the beds and other resources. And our apex body provided us with guidelines on infection prevention and control, testing, quarantine, and self-isolation. With the infection prevention and control, we have lots of guidelines for each area of care, for hospitals, for aged care, for disability, for mental health, for community health, and so on. with the testing, we did really well. We had strict criteria on whom to be tested at the beginning of the arrival of these COVID suspects. And then we stick with that because we never went into a stage of community transmission. Also, we have strict rules on quarantine and self-isolation. So any overseas traveler will be quarantined for 14 days, and anyone who is a suspect or a COVID positive will be isolated until they are cleared. What would we do at the community level? Yes, we received a huge support from the community. Our community strictly observed the social distancing rules and stay-at-home instructions. We've seen very minimal discrimination towards our healthcare workers. Our healthcare workers are considered as public officers, and any offense towards a healthcare worker is taken seriously. They'll be penalized according to the severity of the offense. We've seen huge community health support from the we've seen huge support from the healthcare workforce through social media and media. We've seen some offers and discounts by fast food outlets, special shopping hours for essential workers, special promotions from rideshare companies, and so on. Let's look at the response at the organizational level. So each hospital is under different healthcare services, and based on the guidelines of World Health Organization and Department of Health Australia and the state Department of Health, we develop these guidelines and follow those rules. So we have designated COVID clinics to take the pressure of the hospitals and GP practices. We have COVID boards or COVID blocks. So in my hospital, we emptied out a few wards on the medical block and prepared them specifically for COVID patients. And the standing agenda for daily meeting was to ensure the availability of beds, ensure the availability of staffing, ensure the availability of PPE and other resources. So all our resources and energy was concentrated on containing this COVID pandemic. Continuing with that, we have seen huge changes in the training and education. So our training and education was mainly to reinforce hand hygiene practices, PPE donning and doffing, and we were kept informed of the current updates from Department of Health. We have also seen changes in visitor policy. No visitors were allowed for a COVID positive or a suspect patient. No children allowed in the hospital. And we have seen restricted visiting hours and number of visitors were restricted per patient. We had strict security checks and swipe card access at the entrances to limit the traffic in and out of the hospital. Continuing with that, at the patient level, we have seen strict screening of patients at the point of risk contact. So as I mentioned, if a traveler from overseas or interstate arrives, they'll be taken direct to hotel quarantines. And they will stay there isolated unless if they develop any signs or symptoms. If they develop signs or symptoms, they will be contacting their doctor and get advice. They don't rock up to the hospital and spread around the infection. If they are very unwell, they will contact the ambulance people or paramedics and they'll be reviewed and they'll make the decision whether the patient needs to be taken to hospital or not. This gives hospitals adequate time to be prepared. Depending on the severity of the condition, we'll decide if they need to go to ICU or if they're going to go to the respiratory ward. We don't just admit any COVID suspects or COVID patients in general wards to minimize the risk of exposure. So early identification, isolation, and use of appropriate PPE. In our setting, we use carding system. So droplet precautions, that's if you suspect influenza. Winter season, we have lots of influenza patients coming, but with COVID, our government urged all population to get vaccinated for influenza. So this year, during the winter, we haven't seen that many influenza patients. So if we suspect that they're only influenza and not COVID, we card them as with green card, droplet precautions. So if they're a COVID suspect or a COVID positive, we use droplet precaution and contact precautions, that's beige card. And if we suspect they're going to be airborne, so we use airborne precautions and contact precautions, that's going to be red card. So droplet precautions needs a single room, droplet and contact precautions beige card needs a single room, but airborne precautions will need a room with negative pressure. That's the difference. And also we made sure that we minimize the movement of patients from one area to another. So at the first point of contact, we decide where they're going to be admitted. So if we think they're going to deteriorate and will end up in ICU, we try to get them either into a respiratory specific ward where we have facilities for non-invasive ventilation and negative pressure rooms, or they'll be taken directly into high dependency or ICU to minimize the movement of patients from one area to another and to minimize the spread of infection. And we also have guidelines on perioperative care for COVID positive and suspect patients. So we do strict screening of elective patients. And if they are a suspect or a COVID positive, we try to postpone the surgery if possible. If that's not possible, and if it's a category 1 elective surgery, we have to do the surgery. So we will have strict guidelines on how to manage those patients. And for emergency presentations, we try to manage them conservatively. And if it fails, we go to the operative management. Also, we'll prepare the patient appropriately. We'll time it towards the end of the list, and we'll have a negative pressure room available, operating room available for that patient. And they will be looked after appropriately during the postoperative time. We also have guidelines on goals of care for COVID patients. Goals of care means ceiling of care. So if we think the patient is going to deteriorate, if they're elderly with lots of comorbidities, age is not a barrier for giving care, but still, if we think the outcome is not going to be very good, we will have goals of care in place. This gives us clear guidelines on how to manage the patient in case of deterioration. We don't want to intubate a patient or ventilate a patient if the outcome is poor. That's going to take up an ICU bed and a ventilator, and it's going to drain our resources. And also, we try to avoid aerosol generating procedures as much as possible. And if we think the patient is going to need aerosol generating procedures, they'll be admitted to a room with negative pressure. Also, at the staffing level, we've seen a pool of COVID trained nurses were created. I've seen a lot of expression of interest sent out to accumulate a pool of nurses who are willing to work extra hours and who are willing to work in COVID specific areas in order to spare other nurses who work in general areas. We have seen some PPE expert to ensure donning and doffing of PPE is correct. They'll be there 24 hours to make sure staff is following the protocols and they are safe. We do a fit check prior to attending a COVID patient. And if we fail for some reason, because if they have long beard or if for any anatomical reasons, if it's not appropriate, the staff are not allowed to attend to COVID patients or COVID suspect patients. And staff who work with vulnerable patients are exempted from COVID duty. For example, if you generally work in an oncology area, hematology area, or in transplant areas, they are not allowed to go to COVID area and look after patients there. And also some hospitals provided staff with accommodation facilities, and also hospitals provided them with scrubs so that they can leave the scrubs behind and have showers and get clean before they go to their home or accommodation facilities. What did we see in unit level? So we have flexible rostering and swapping arrangements in order to protect our people who have other demands at home, like if they have young kids, if they have elderly parents to look after, if they have childcare issues and things. So we have flexible rostering and swapping arrangements. And also we want to protect our vulnerable staff. So if you have a COVID suspect or a COVID positive patient in your ward, we want to protect our pregnant nurses, or nurses who are immunosuppressed, or if we have nurses with other comorbidities with respiratory problems and diabetes and things like that. Also, we have COVID team and clean team. If you have patients, general patients and COVID patients in the same area, same ward, so we try to keep 2 separate teams in order to minimize the contamination. Also, we have strict guidelines on how many people or healthcare personnel go into a room if there is an event of code blue. We don't want all the people to go in there. So if it's just an escalation of care, we'll have one doctor and a nurse inside the room, and we'll just receive instructions from outside, where the other team is standing outside and give us instructions. And if it's an event of cardiac arrest, if we have goals of care in place, we follow that. Otherwise, minimal number of people will enter the room, and the decisions are made quick enough to minimize the exposure. Also, if we come across a COVID positive patient and if we suspect that we're going to get sick, we can take paid sick leave until we can clear that. What was the individual response? So, as we all know, when we heard about COVID, we were all scared about the pandemic. Had fear and anxiety, fear of catching and spreading the illness, health and well-being of our family, because we have young kids, we have elderly family, and also financial stress. Because as I said, we canceled the elective surgeries in our hospitals. Lots of agency and casual nurses lost their job, or they fear they will lose their job because we didn't see the community spread here. Our hospitals went so quiet. And also social stress. Because of the social distancing rules, people were not able to socialize as we used to do. Also, mental stress. If the vulnerable people, we have seen a lot of suicides and other problems in the general population as well as among the healthcare workers. So this was the individual response. If you look at, even though we were all prepared, we still had that fear of catching this disease and even fear of death. And also, migrant workers like me who have family abroad overseas, we think about them. That's adding to our stress. So what support we received? We received really good mental health and well-being support. So in order to ensure the capacity of the healthcare workforce, we need to boost their mental health. And we have seen good leadership and management, and also our managers played a vital role in setting the culture. They were all visible when we needed, had really good open communication, debriefing, and even during weekends and after hours, we have help 24 hours a day. Staff were encouraged to seek assistance. We have several employee assistance programs, web-based information, and national helplines. And we can also approach our general practitioners if we need more help. Also, we have a culture of mutual support. We support our colleagues. We're kind, respectful, and compassionate to others because we don't know what's going behind. Everyone has got their own stress in their life. So we try to welcome each other with a warm smile at the beginning of the shift. We have some small chit chats. We want to make sure they're all safe, they're all happy, they're healthy, their mental health is good. And also, just by simply asking, "Are you okay?" will do the job. We can explore their feelings and emotions. Looking after their mental health and well-being. So looking after mental health is equally important as looking after your physical health. How can we do that? Stay connected with family and friends through social media and phone. Get enough sleep, keep active, and get out in the fresh air by exercising in your garden or in your balcony. You don't have to go to a gym or a park to do that. Talk about how you're feeling with your friends and your family regularly. Reduce alcohol intake and get your hobbies out to keep busy. I've seen a lot of artworks and also cake makings and lots of cookings from my friends through WhatsApp and Facebook and things like that. About to conclude. So we know we are the most valuable resource for health, and it's our responsibility to look after ourselves and each other. So our safety first. If we are not safe, we can't look after sick people. So stay safe, stay healthy, stay happy. Thank you. I thank you, Panama Madam, once again, and also all the organizers and also my little ones for the technical support. Thank you.
Thank you, Mrs. Chitra Ebi, for highlighting COVID-19 related data from your region, especially the biological disaster response at various levels. Thank you. Next, we are happy to have Mrs. Ansi Chaco, an alumni of CMC Vellore. She has a master's in nursing and many other certifications in her credit. Currently, she works in the capacity of a charge nurse, St. Helens and Knowsley Teaching Hospital, NHS Trust, Liverpool, United Kingdom. On behalf of the organizers, may I extend a warm welcome to you. Over to you, Mrs. Ansi. You have to unmute, Mrs. Ansi.
Can you hear me now?
Yes, now audible. You can
May I-
start.
Good afternoon, everyone. I'm Nancy. I work as a charge nurse here in the NHS Trust in the UK. Thank you very much to the organizers for giving me this opportunity to share my perspectives about tackling COVID in the UK and Europe, precisely in the UK because I work here. So could you please share my slides? Yeah. Moving on to the topic, protection of healthcare workforce during COVID-19 pandemic. Just to give you an overview, initially, the COVID began, or the first case was reported in the month of January. Towards the end of January, first European case was reported on 24 Jan from France, and first case in the UK was reported on 29 Jan 2020. Next slide, please. Overall, until yesterday, so far we have got 1,675,022 cases reported throughout UK and Europe. And as of yesterday, 181,626 deaths that's been reported in the UK and Europe. We do not have an exact number of healthcare workers who have lost their lives in the pandemic, but roughly it says it's about 500 in the England and Wales itself. Next slide, please. So this is just a quick overview about how cases have progressed right from the month of January till now. So during the months of March, April, and May, that's when we had the maximum number of cases where we have actually struggled to deal with COVID in the country. Moving on to the next slide. What the government has done initially, the first few weeks, even Mr. Boris Johnson admits that we did not understand COVID the way we should have, ideally. So there was a bit of delay in putting every possible measures in place. People were categorized into three groups, like clinically extremely vulnerable, clinically vulnerable, and low risk. This was purely based on their health condition and age. Next slide. So under the clinically extremely vulnerable group, we had solid organ transplant recipients, people with specific cancers who were undergoing chemotherapy, radiotherapy, who were having blood cancers, who had immunotherapy, who were on immunosuppressants, who had severe respiratory conditions like asthma and severe COPD, who had inborn errors of metabolism. And there were other people as well who were categorized by their doctors as clinically extremely vulnerable. Women who were pregnant with significant heart disease, congenital or acquired, were also put under the category of clinically extremely vulnerable. Moving on to the clinically vulnerable. So could you go past a bit? I've actually gone past a bit on the slides. Clinically vulnerable people included those above age of 70 and with chronic heart conditions or lung conditions, kidney diseases, neurological conditions. Diabetes, those who had issues with the immune system like HIV and AIDS, those who had high BMI, and those who had issues with their spleen, and those who were pregnant. So based upon their clinical condition, instructions were given about shielding. The highly vulnerable group, that is the clinically extremely vulnerable group, were advised to shield from the end of March until July. They were not allowed to go for work. They were advised to stay at home. Every possible amenities were brought to their door, including food and medicines. They were supposed to be maintaining social distance between the family members within the home itself. And the clinical vulnerable people included pregnant women as well. Pregnant women were supposed to be following the guidelines given by the Royal College of Obstetricians and Gynecologists. Those pregnant people, including the healthcare workers who were less than 28 weeks pregnant, were allowed to work in a less risky area where there is a minimum exposure with COVID patients. Whereas pregnant healthcare workers were not allowed to be working with direct patient care, and they were advised to stay at home as much as possible or work from home if possible. Recently seen that the cases have deteriorated so much from the times when we had nearly 900 deaths a day. It has dropped down to like 20 to 30 deaths a day, which is a massive difference. We have been initially struggling a lot to deal with the vast number of cases in the hospitals and the care homes. So the guidelines have started changing. The lockdown, which started on March 23rd, have been relaxed gradually. By around the end of June, many relaxation measures have been taken. Like people were allowed to go out, get into groups, meet in pubs and stuff. Shielding policy as well changed from 6th of July. Those who were shielding were allowed to meet outdoors in a little group of maximum of 6. They were allowed to form bubbles or bubble groups with another family or household. But the clinically extremely vulnerable group were still not allowed to go back to work, and employers were supposed to be meeting their payment needs as per the policy. Now, this shielding policy, again, it's coming to an end in the next 3 days. From August 1st onwards, as per the government guidelines, no one requires to be shielding. People could be going back to their work, and the employer needs to do an individual risk assessment based upon their need or based upon their condition. And if necessary adjustments need to be made at the employment level, or staff need to be redeployed as and when it's needed. Now, discussing about a bit of concern what we had in the trust or in the healthcare scenario. There was a disproportionate impact of the virus on the NHS workers, or generally healthcare workers, from the Black and minority ethnic backgrounds. There were a large number of people affected from this background compared to the rest of them. Hence, every employer was requested to do an individual risk assessment for any staff member, any healthcare worker coming under the category of pain, based upon their age, gender, ethnicity, disability, health condition, and pregnancy. And they were categorized into mild, moderate, and severe risk. Those staff members or the healthcare workers who came under the category of severe risk were advised to stay at home. Those who came under moderate risk were given options to move into a different work setting where there is a less risk of exposure with COVID. And those who were having mild risk were allowed to continue to work. How tackling of COVID began? Initially, people with minor symptoms that could be managed with paracetamol were allowed to stay at home or were advised to stay at home on self-isolation. And the family members of these people with symptoms were also advised to stay at home on self-isolation for 14 days. This was the same in case of healthcare workers as well. The symptomatic patients were tested as soon as possible in either drive-in test centers or the hospitals, or home visits were also arranged for those people who cannot get out to a clinical setting. People with severe symptoms required hospitalization, and they were treated initially in single rooms in general wards. Unlike in our country, unlike in India, I would say, we do not have a specific isolation ward here. Instead, we do have separate single rooms in each general ward. And I work in a general geriatric medical ward. And we do have like a few single isolation rooms. So initially when the cases started coming up to the hospital, they were isolated in these single rooms. But practically, I personally never felt that this was giving a lot of barrier, because the same staff members would be taking care of them in the isolation rooms as well as in the general bay, which actually caused a bit of concern about cross-contamination. Later on, as the cases progressed, many general wards were changed or transformed into designated COVID wards to allocate only COVID positive patients, with a certain number of low-risk healthcare workers allocated into each COVID ward. IT facilities were also extended to accommodate the number of cases. When speaking about the healthcare workers who had underlying medical conditions were risk assessed based on the individual circumstances. Wherever possible, healthcare workers were encouraged to work from home. Only the very essential clinical staff were encouraged to come to hospital to do their job. Where it was possible for staff who were at risk of developing COVID compared to the rest of the staff members or the healthcare team, were deployed to a less risky area like education and training department. It was advised that social distancing should be followed by everyone within the hospital and outside, but unfortunately, that's something that we could not actually meet at the beginning of the COVID pandemic. PPE appropriately to the work settings. I'll come in detail about the PPEs. All the symptomatic healthcare workers and their family members were tested as soon as possible, and they were given paid leave, paid COVID special leave, until they were better enough to come back to work. Right from the beginning of the COVID pandemic, there was daily departmental or hospital meetings to discuss about where we are or where we are up to with dealing with COVID, or how else we could tackle it. There was daily update given on COVID guidelines, which was emailed to every staff member. Infection controls provided guidelines about PPE and social distancing. Unfortunately, in the beginning, with the cases that come to the hospital, that was something that we were never expected, or we would never expect. That was such a huge flow of inpatients, and staff really struggled. Healthcare workers really struggled a lot to deal with them. Scientists have recently warned about the second wave of COVID, especially in the months of winter, that could be coming up in the next few months. So in order to tackle or in order to prevent such a second wave, infection control departments are taking every possible measure to stop having or to prevent having such a second wave of COVID. Overall, we have lost more than 45,000 lives here in the UK itself so far. So recently, within the last couple of months, infection control started doing spot checks to the wards, made PPEs and social distancing very strict, mandatory. And every single room in the hospital premises has been assessed for the capacity of healthcare workers, like how many healthcare workers can be accommodated, maintaining the social distance within the room. And when there is a possibility that the social distance could not be maintained between the healthcare workers within a close proximity, it was advised that a full PPE should be worn by the healthcare worker. Moving on to slide number 18. The capacity of the hospitals to test for COVID was a bit of concern at the beginning. Only those symptomatic patients were tested for COVID, or only symptomatic staff members were tested for COVID. And gradually what we have come across was many patients, so general patients who did not have any COVID symptoms, who were admitted into the hospital with acute medical conditions, developed symptoms similar to COVID. We were ideally looking out for the symptoms like fever, cough, and loss of smell and taste, etc. in the beginning. But I myself have experienced that my own patients who became confused all of a sudden, who became lethargic, whose temperatures was only slightly raised, like around 37, 37.5, etc. So these patients, when we tested for COVID, they were positive, and they were all on a general ward, not isolated at all. That was a great concern. And gradually, the hospitals, NHS Trust, implemented the policy to test for every single patient coming to hospital for COVID right at the time of admission itself. And if the first swab comes back negative, they were supposed to be having a repeat test after 5 to 7 days after the admission. Talking about the PPEs, in the general wards where there is a very less risk of exposure to aerosols, it was advised that the staff members, the healthcare workers, could be using the fluid-resistant type 2R surgical mask, apron and gloves, goggles and visors as required. FFP3 mask was advised to be used along with the disposable fluid repellent coveralls or long sleeve disposable fluid repellent gowns in cases where there is a risk of aerosol generation or depending upon the patient's situation. Staff members were trained to use the PPEs and they were fit tested for the mask as well. The main concern around the PPEs was initially, or the main challenge was, we did face a shortage of PPEs right at the beginning of the pandemic. And then at one point, the surgical masks, the type 2R ones that was provided to us did not provide an actual seal around the face or the nose, which caused a deal of stress and anxiety among the staff members. These issues were resolved gradually. So the aerosol generating procedures were listed as respiratory tract suctioning, bronchoscopy, manual ventilation, intubation and extubation, tracheostomy, as you can see, NIVs, high flow oxygen, oscillatory ventilation, high frequency, high flow nasal oxygen, dental procedures, etc. Mostly these aerosol generating procedures are something that's been done in the ICUs or ITUs, and hence everyone who's working in the ITUs or a COVID unit were given the full PPEs, and whereas in the general ward, only those staff members who were taking care of the COVID positive patients were advised to use them. Strictly, there was no visitors allowed within the hospital premises except to those people who were actually end of life or who have actually lost their lives. Only one visitor was allowed at that point. Birth partner was allowed to stay with the pregnant women only at the time of the labor. There were no visitors allowed in the care homes as such until recently. Now the local policies have been changing. So based upon the local situation of the COVID, it's been agreed that care homes can admit one visitor per person or per patient. Regarding the discharge and transfer of COVID patients or the patients who have been in the hospital, every patient was supposed to be having a negative COVID swab result at least 48 hours prior to the discharge plan. And some discharge destinations even admitted a COVID result 7 days prior to the discharge. And throughout the hospitalization, when a patient was transported between the departments for investigation purpose, or like initially patients who were brought to a general ward, once they become COVID positive, they were moved to a COVID unit. So while the patients were transported, they were advised to be wearing the type 2 surgical mask and gloves as well. As an infection control policy, healthcare workers were insisted to be coming to work or going back from work in their own clothes, not to be wearing uniform anywhere outside the work setting. They were advised that the uniform should be washed at a minimum temperature of 60 degrees Celsius. Hand sanitizer, mask and social distancing was made mandatory within the hospital. Antibody test was started for the healthcare workers, but there was a controversy in this case again. Though I've seen people who never had COVID symptoms who had antibody tests that's come back as positive. Also, I've seen people who have been tested for COVID and who had positive COVID-19 results previously ended up with a negative antibody test result. Also, it started to test regularly, bi-weekly COVID tests for the care home staff recently. That was based upon the situation that there were many care homes where we had huge outbreaks of COVID. Designated COVID ambulance with paramedics using full PPE to transport patients with COVID symptoms were used. Talking about the psychological support that was made available for the healthcare workers, there was a mental health hotline that worked throughout from 7 o'clock till 11 p.m. in the night. That was launched by NHS to support the mental health needs of the healthcare workers. Anyone who could call into the SN phone number to ring up and speak about their concerns that was dealt with. Specific team was organized within the hospital settings to help the healthcare workers who are struggling to cope with the increased needs and the situation of during the COVID pandemic. Mindfulness therapy was offered, and those staff members who really struggled out of the stress and anxiety from the COVID was granted special leave, sick leave, paid sick leave to stay at home until they get a bit better. As I've told you, the challenges. From my own personal experience, I would say even though we had strict guidelines about the use of PPEs in different settings, I myself have noticed that the PPE was not used based upon a common guideline in all settings. Different guidelines were followed in hospitals, care homes, and community centers based upon their capacity, which caused a great deal of stress and anxiety among healthcare workers. For example, in the wards, in the general wards, or in the hospital settings, we were asked to swab people wearing the surgical mask, the type 2 surgical mask, blouse and apron. Whereas when you go out to a community health center to get yourself swabbed, you will notice that somebody is wearing all FFP3 masks with the proper full sleeve gowns and stuff, which caused a great deal of disparity among between the guidelines. Due to the vast number of cases, it was only possible to deep clean those rooms or spaces that's been used by patients who had a positive COVID swab result or COVID results on the lab test. But those people who are symptomatic, who are waiting for the COVID results, if they get moved, often their rooms or spaces was never deep cleaned, because of the large number of cases, it is totally impractical for the health settings to arrange for a deep clean due to the cost and due to the manual labor. Due to the shielding policy, healthcare workers who came under the category of high risk, clinically extremely vulnerable, were allowed to stay at home on full pay, which has actually led to the shortage of healthcare workers in this busy scenario. This ultimately ended up in causing an increased work pressure and stress among staff. First of all, the shifts were extremely busy, having so many poorly patients. Due to staff sickness and shortage of healthcare workers, the regular staff members had to be doing overtimes and extra shifts to cover up the needs of the unit. Healthcare workers, many of them had to choose to stay away from the family, and there were plenty of staff members who did not see their families or loved one for a great deal of time throughout the pandemic. Thank you very much. I hope I'm clear. This is purely from my own experience dealing with COVID patients and seeing how we have tackled COVID in this country. Hope that was a bit helpful at least. Thank you very much for this opportunity. In case if you have any questions, I'm happy to answer. Thank you.
Thank you, Mrs. Ansi Chaco, for highlighting COVID-19 related data and containment activities in your region. Thank you very much.
Thank you, sir.
We are delighted to see that there are 1,000 and more live audience, both in Zoom as well as in YouTube streaming. We have two esteemed panelists from American region. First, let me introduce Mrs. Binol Rajesh Balachandar, RN, MSN, and a DNP scholar from West Indies. She has a lot of experience both in the clinical as well as in the academic area and worked in various capacities. Presently, she is in the capacity of lecturer, program leader, post-RN completion degree program and franchise program, and also coordinator in Caribbean School of Nursing, University of Technology, Jamaica, West Indies. On behalf of the organizers, we extend a warm welcome to you, ma'am. Over to you.
Good evening, all. Thank you, Dr. Sajid Kumar. Thank you, Panama Madam. Thank you, all the organizers for allowing me to present today. Before I go to my presentation, I would like to introduce Jamaica. Hold on a second. I'm just sorting out my slides. Okay. Can you all hear me well? Can you see my screen?
Yes, ma'am. Can you put it in the slideshow mode, ma'am?
Slideshow? All right. All right. We'll do. Oh my dear.
Ma'am, now it is fine, ma'am. Madam, please unmute. Your slide is now okay. Madam, please unmute. Your audio is muted, ma'am. Please unmute.
Hello. Yes, it has been done. Thank you so much. Okay, so I'm from Jamaica, West Indies. It's one of the Caribbean islands. And this is a beautiful island, similar to Kerala, except that we have a lot of white sand beaches. And this is like, I would say, it's Kerala, outside of Kerala. To be precise, Idiki, outside of Idiki. That's where I am from. So we have population of 2.95 million or 29.5 lakh. And we actually receive a lot of tourists because it's a tourist place, and we actually market the place well because we have vegetation, rocky cliffs, beach coastlines, valleys and mountains, which is almost similar to Kerala. And we also have a lot of legendary personalities Jamaica has produced, like Bob Marley, Usain Bolt, Asafa Pal, Merlin Ottey, Chris Gayle, Shelley Fraser Price, Johan Blake, to name a few. We have so many others that I have not mentioned, but these are the names that the new persons must be more familiar with. And for the COVID scenario in the West Indies, Jamaica, we have so far 19,935 cases of the 45.29 million people across Caribbean. And Jamaica is one of those Caribbean islands. And in Jamaica, we have 842 confirmed cases and 714 fully recovered cases and 10 deaths. And the recovery rate is one of the highest in the world, which is 85%. And it is, I think they are updating that soon, so it could be higher too. And we have statistics from Jamaica in the sample tested, result pending, all of that, which I am not going to go into the details. How do the data help? Because sometimes the accuracy of the data, the quality of the data, consistency and timeliness of reporting the data are really important, because from the healthcare perspective, this is important for employees and employers to implement preventive measures. And we are not short of policies and protocols either. There are a lot of protocols and policies that are developed based on the WHO and the CDC guidelines, because Jamaica, as it is a very small Caribbean island with a smaller population. So most of, and proximity to the United States, because we are just 1 hour away from, by flight from Miami, and close to Cuba geographically. So most of this policy and the development of protocols are based on the US standards or based on the WHO or the CDC guidelines. And then Ministry of Health and Wellness. I think it is the one Ministry of Health that is in the world, which is also named as, which is called as Ministry of Health and Wellness in Jamaica. That is how it is called, Ministry of Health and Wellness. I think that is one ministry all over the world that you would hear in that name. In wellness is included in the Ministry of Health. And that Ministry of Health actually follow the protocols and policies. Develop policies and protocols based on the CDC and WHO. And all the organizations, the nursing associations, nursing councils, medical association, dental association, pharmacy association, physiotherapists, all the healthcare workers and the organizations follow those protocols developed by the Ministry of Health. They base the development on the CDC and WHO. So you would see a lot of things are similar. So in the early stage of the disease or reporting of the disease in the island, a lot of things that we did is similar to the measures that we heard from Australia. And I think in Kerala also, we did really well. The Kerala model, I would say, which was very similar to Jamaica. Jamaica policies and the protocols or the measures taken were similar to Kerala model. That is what I meant to say. And then, as you know, in Europe and US, sometimes due to the human rights and the policy issues, the measures that we took in Kerala or in Jamaica, which cannot be implemented in some of the part of the world, like in USA or in the UK. So in Jamaica, we could implement some of the measures that wouldn't have implemented in the rest of the world or in the USA. When I say rest of the world, the Europe or the USA, because imposing certain restrictions were a challenge in US or some part of the Europe. So, but in Jamaica, which was implemented similar to Kerala model, because of the cultural or socio-cultural similarities, though the most of the other cultures are influenced by the US, but in terms of social relationship, which is similar to Indian culture, so the measures implemented were similar. And so we had all these restrictions that you see on the screen, which I'm not going to repeat those. We had separate COVID units, all the workforce were identified, the staff members were identified, security personnel were called in, they were the area were contained, all of them were done. And then the policy measures, if you can look on the screen, there are a number of policy measures that were implemented, which is available in the website, Ministry of Health and Wellness. All of these policies were implemented from March to May. It is still being revised, and you can see a number of measures, including the staff, business places, isolation, home quarantine, everything is clearly specified in this guidelines. So all of these are the protocols and guidelines available for the health workers. And this one, it is not so clear when I pasted it. It is also from the Ministry of Health website. This is also a guideline that is given to the home quarantine and also for the isolation. So considering all of this, how it affect the nursing workforce, I would say the healthcare workforce in general. How can we do? We heard a lot about infection prevention from across the world, and we all know a lot about how to prevent COVID. But I would like to emphasize a few points. This year has been selected as the year of the nurse and midwife by the WHO, because 50% of the world's health workforce are nurses. And then this year has been career defining for nurses and midwives. Like Florence Nightingale in the Crimean War, now we are fighting coronavirus in a different form. So the nursing leadership and the nurses are, in general, we did step up. And it is time for us to showcase our leadership and organizational skills, thereby improving the visibility of our profession. When pandemic or when we are tested, not just during pandemic, otherwise too, how are we influencing the policies and the decision making by the government or by the organizations? How are we improving the visibility of our profession? By leading the way, because most times the nurses are trailblazers, but we are not visible in our organizations or in our profession or in our country. But we always hear the sweet talk, and sometimes we are not visible otherwise. We are the experts in it. When there are policy measures or protocols implemented, are we part of it? We need to examine, we need to analyze that situation. We need to actually do an introspection of what we are doing, what our leaders are doing. How can we change or influence the policy decisions, sometimes which is imposed upon us, but without any involvement in the policy making. So save one life, as we say, you are a hero. Save 100 lives, you are a nurse. And each one of us are angels with one wing, but we can only fly embracing one another. Therefore, and we know we are willing, but do not overdo it. Not all are going to be privileged to be celebrated when we lose our lives in the line of duty. It doesn't mean that you had to give up. You shouldn't work. You shouldn't try. We should, but we are not supposed to be carried away by the sweet talk and flattery. But at the same time, do what you can, but try and change. Try and stand up when we have to, because as you know, infection prevention, we all talk about infection prevention. I do not want to go over the same thing that we heard and we are talking about, because we all know what to do. We know how to do the PPE, don the PPE, how to take off the PPI. We know all of that. But then when we overdo it, we are actually spoiling our immune system, and we are actually making ourselves vulnerable to get the disease. So we need to examine what we are doing and how we are doing it. Having said that, I want to go over some of the things that we have not mentioned in the previous presentations. We have, I mean, in the US, there's an organization called Occupational Safety and Health, which has had some interim guidance on how to care for the patients, or the protocols and the guidelines that are given by them. The time period that we should be used to contact tracing after exposure to asymptomatic individuals who test positive for COVID was 10 days, but it has been shortened because it is said that when the person is asymptomatic, the viral load is low. So even if you test, you may not actually really, we are wasting the resources or limiting the chance of identifying. So limit the exposure time to testing to 2 days from the 10 days. So that was one that was implemented here, as well as the definition of exposure. Oh, sorry, I want to go back to the slide where I said the time period that is used for contact tracing. Before that, the duration of exposure is considered prolonged if the exposure occurred during performance of an is aerosol generating procedure. And sometimes I'm not sure if you are considering the mouth care and oral hygiene in whichever way. Even if it is not a suctioning, sometimes I think we need to also consider when we are doing the mouth care and the procedure that involve body secretions. So now also the work restrictions. Previously, we used to isolate the person or quarantine them when we have any exposure at all. But those restrictions were lifted. Even if you have exposure, we still, in all over the world now, they will still report to the work. They will still report to work, and they will still do everything as they were doing without going into isolation or quarantine, which is also a change that we see recently. So just like any other isolation or quarantine or COVID wards, these measures were also implemented in Jamaica. The responses or experiences of nurses in Jamaica, they were scared, they were willing, but they were scared. And the psychological support of the family and the counseling of the community was needed. The commuting or the traveling and by bus and the accommodation were challenging sometimes, just like what we heard in India. So, we heard incidents of the landlords not allowing the nurses or the healthcare workers not to board, things like that. It also happened here. And the commuting, sometimes it has also happened, the taxi men or the public transportation were not taking nurses to commute to work. So it was also created a bit of drama on the road. And I think it was by policy level, the government interfered, and then they made it very clear that if you're not letting them go in, then their license will be cancelled. So that was dealt with. But those were not the nurses who were in the on COVID duty. But then in the beginning, I'm talking about in the beginning, when we all heard that COVID is in Jamaica, there was only one case, but the people were afraid. So eventually the persons working in the units were incentivized, and approximately, I am converting it into the Indian rupee, approximately 1,500 rupees per day, and the meals were provided for all the nurses and healthcare work. I mean, healthcare, I'm talking about nurses who were working in the COVID wards. and they were given coupons. The businesses and the organizations, they actually bring in sandwiches, flowers, cards, thank you notes. They also got special discount coupons, just like we heard from other part of the world also. It all happened. And so many, I would say, experiences was generally good after the initial crunch. I also found this study where that was done in China, of course, in the beginning. We need to be, we all heard about the surfaces and the contamination of the surfaces. Out of the researchers actually identified 13 zones. Out of the 13 zones, the most contaminated objects were service printers, desktop, keyboard, and the doorknobs. And hand sanitizer dispensers, gloves were the most contaminated in the PPE. And the gloves were most contaminated among the PPE, but then hand sanitizer dispensers were also contaminated. So really, it is important for us to keep those in mind when we are talking about infection prevention. This will also help us to know, focus on the staff education, environmental cleaning, and also we need to also, when I say staff, it's not just the nurses, because we know we have support staff, we have the janitors, all of them need to be included in those activities, so that they are aware that these are the areas. I mean, it doesn't mean that we have to focus on that area alone, but awareness is always important. I would also say conserve resources for sustainability, because we are short of equipment and supplies, and many a time we overuse it or waste it when in the beginning. But we have to understand that maybe harder times are ahead, and we need to sustain or maintain the supply of the PPE or other resources in general. So sustainability, conserve resources, which is important. Integrating behavioral sciences in modification of behavior, because which is very, very important in disease prevention. We all heard, we learned theories of behavior modification, but as you know, education alone is not a guarantee that people will behave always that will help in prevention of infection. We heard enough examples from healthcare workers. I don't want to name anybody or any particular sector, but we have had enough examples where the healthcare workers themselves putting the patients and others around them at risk. So education is not always guarantee that we have behavior change. So integrating behavior sciences, it is very, very important in management of patients, as well as prevention of infection, which is very important. That is what I'm talking about here, prevention of infection among workforce, behavior modification, because we all know, we all are used to certain way of doing things, but it is time to change. So it is time to change, not just for the healthcare workers, for others too, because now we come home and wash hands, and we do certain things that we never used to do. So behavior modification, prevention of infection, which is two concepts that always are very intertwined, or interconnected. And as health professionals, I have seen a lot of people sharing information that are really, I would say, nonsense, utter nonsense. And sometimes we will wonder if these people really are health professionals. So stop sharing those information when we know that these are not authentic. Do not share them. If we are in doubt, ask questions. So that will actually cause misinformation, because as health professionals, we have a role to play in infection prevention by role modeling. If you, as a health professionals, you come to the community, you and your family are doing things that are not helping in infection prevention. How are we going to educate the public or other persons? So infection prevention is not just in the hospital. If we want to prevent the infection transmission, role modeling by the healthcare professionals are very important. Then the mental health, we spoke about it and we heard that there were counseling and support. And in maybe we have a lot of preoccupation or we do not really consider mental health counseling or support is very important. Maybe some of us don't need it, but then many a time we do not identify those persons who need it, because when your mental health is affected, sometimes we do not care about infection prevention because it doesn't matter to you, because maybe you are depressed, you are suicidal, and we need to understand that, ask, consider, support. And then when we identify those, we'll be able to manage them better, and we'll be able to identify practices that might be risky or might be a safety threat to self and others. Which adaptation to the new norms and working differently, which I mentioned already. And we need logistic support and policy and protocols to do it, because sometimes we educate them, but we don't have any guidelines actually to look at in case if we are in doubt. So we need to make available those information in the ward for anybody to refer. Being mindful of global challenges, because we know economic crunch, climate change, changing attributes of persons, especially the young professionals, graduates, because I would say I am old fashioned, I'm from old school, but I cannot say that my students or the people I work with have to behave the same way, because they are millennials and their behavior, their expectations, their attributes are different. So we need to understand that when we are planning the education protocols and the policies, because that will guide us in how to train them, how to help them with the behavior modification using the social, behavioral modification principles based on the behavioral sciences. So it is important to know the adult education, the science behind the millennials behavior. All of that is important. Innovative approaches to managing patients, especially the home quarantine and isolation. We could incorporate telemedicine, telehealth, which will actually reduce social contacts. And then this technology have connected people all over the world. Right here I am in the Caribbean, and I am talking to you and you are seeing me. The same way we could use it in medicine and nursing, because sometimes the community health nurses, you don't have to go there sometimes to see the patients. We can actually talk to them over the phone unless it is necessary. We do not have to go. So those things can be incorporated. I think we have the infrastructure, because Kerala especially, we have a lot of infrastructure and the people are aware, mostly I would say. And then telemedicine and telehealth, it could be a viable alternative. I talked about the role modeling with the previous slide. So I think we need to understand the role modeling, because many a time if we take it light, everybody else is going to take it light. And then very importantly, we have a tendency, especially specifically for nurses, we nurses eat our young alive. That's what it is called. And I think it is important to also take suggestions or opinion from our young, because they may have innovative ideas. Do not suppress them down or put them down, because we might say, oh, I've been in this profession long enough, so I don't need your advice. Sometimes we need to come out of that attitude. They may have a better solution to the problems. Now, of course, somebody was talking about the child support and all in the previous presentation. I think it is from Australia, and I am sure that is important, because sometimes people with disabilities, you may be caring for your parents, children, or somebody who has disabilities in your home and in your absence, really it is challenging. So if the organization, especially we have nursing association, nursing bodies, we have a role to play in terms of ensuring that those things are done. I'm not saying it has to be done for everybody, but we have to prioritize and see if they need support, we have to provide. We do not give the support when we expect the nurses to come and work, work in their full capacity, but their mind is somewhere else. They haven't eaten, maybe they haven't slept. Who is taking care of them? And we talk about infection prevention, but we do not consider the factors that might need to be considered. Bargaining and welfare bodies, which I think associations spoke about. We need to also improve the standard of nursing practice and safe ethical work environment and bolstering the health and wellness of nurses. If we don't do it, if we do not try and influence the policy decisions, then we are in trouble. Disease is rapidly spreading, and despite the outcome, nurses and midwives will be at the forefront, making a difference, and we all know that. And as nurse leaders, we must be role models and speak up and speak right for creating an environment of trust while marshalling the team. We are committed to the changes that we would bring to support the healthcare teams through this battle. And I am sure we all do well. We will do well. These are my references. And nurse, just another word to describe a person strong enough to tolerate everything and soft enough to understand everyone. But we will still manage it. This too shall pass, and we have a greener pastures. And this is a picture from Jamaica. And when this is all done, when the airport is open, welcome to Jamaica. Thank you. Thank you for listening.
Yeah, thank you very much, Mrs. Binol Rajesh Balachandar, for excellent presentation, which has given us a bird's eye view about the activities related to COVID containment in your region. We especially acknowledge the pain you have taken to come in the odd time due to the difference in the time zone. We especially appreciate that. Thank you very much. I should also acknowledge Mrs. Lena James, our alumni, for suggesting this excellent speaker from West Indies. Thank you, Mrs. Lena James. We have another excellent panelist from United States. We are delighted to have Mrs. Sandhya RG, RN MSN, who is our alumni too. She has a master's in nursing and has many other certificates and merits in her credit. Currently, she serves as charge nurse, bone marrow transplant unit, and also a member COVID-19 task force. University of California Medical Center, California, United States. On behalf of the organizers, may I now invite to deal with the topic, the perspectives from United States. Welcome, ma'am.
Hi, if I'm half asleep, pardon me, because I told Sajid that I was even not sure that I am able to attend because I worked yesterday and I have to go back to work today. So, but anyway, thanks to Sajid and College of Nursing for giving me an opportunity to, you all can hear me, right? I think I unmuted.
Yes, ma'am, we can hear you.
Yeah. So the question now is, our healthcare workers, including the nurses, is at high, I don't have any slides, sorry. So at risk to get COVID-19 from taking care of COVID-19 patients or not? I would say healthcare workers are at risk, but they are at risk not because they take care of COVID-19 patients. When you take care of a COVID-19 patients, you know that you're going to a room who have going to a patient who has COVID-19. So you take your utmost care. You make sure if your mask, your N95 mask is fitted correctly, you're wearing the face shield, you're wearing the old PPAs, So you take utmost care. So I always believe the risk of getting infection for the nurses is they are not fortunate to stay at home. They are going to work. And at work, unless you practice good social distancing, universal masking, you are at very high risk to get the illness, because you never knew. I was always scared to get the illness from your coworker than from a patient. Even if you're a patient, if you don't know, you test the patient. So I am mostly talking about our hospital, and our hospital's policy is based on the CDC guidelines. So we actually test all the patients before coming. All the direct admits patients has to be tested outpatient before coming to the hospital, and they should have a negative result. If they have positive, they can still come to the hospital, but they will be designated to the COVID, they will be assigned to the designated COVID-19 floor. So your chance of getting infection from, if you're not working the COVID-19 units, most of your patients, you're not at very risk to get infections. And also, if the patient is negative, if the patient is still symptomatic, you will be sent to the COVID-19 cohort unit. And for the nurses, for all the nurses, we do screen every day, not only nurses, all the persons, including the healthcare workers, including the chief nursing officer, chief executive officer, the patients, the visitors, everyone will be screened in the lobby for any signs and symptoms of COVID-19. If they, and also we check temperature for everyone who enters to the hospital. If you have a temperature over 99 degree, or if you have any one of the signs and symptoms, you are automatically redirected. If you're an employee, you will be redirected to the occupational health. And if you're a patient, or you have to go to ED, or if you're a visitor, you will be getting the guidelines what to do next. So this actually helps the employees to get protected from the risk of getting exposed to with your fellow employees. And also one of them, we had some clusters among the employees in our hospital. So when we investigated, there is no scientific evidence, as far as my knowledge from the COVID-19 task force meeting, that any employee got any COVID-19 from by taking care of COVID-19 patients. But most of these are you work in a social setting. So you have your birthday of your friend, or you have to celebrate, if one of your coworkers is pregnant, you have to celebrate their baby shower. So all these opportunities, do you wear mask? No. You have a potluck. You use the same serving spoon for everyone. So these are the things that usually we neglect. So what happened, we actually every day in the huddle, we make sure we explain, or we remind all employees about the universal masking. Like everyone, all patients, all healthcare workers, all visitors, they are supposed to wear a mask inside the hospital. So the only one time you can remove your mask is when you're eating. So when you're eating, we make sure that before our break rooms or nurses' lounge, there were it was a big room. So each room had so many chairs. So now to keep the social distancing, what we did is we removed extra chairs. So there are only 3 or 4 chairs left in the break room. So even if you're eating without the mask, you are at a safe distance from a fellow employee. Same as in the cafeteria, you don't need to close the cafeteria. The cafeteria, because your employees need to eat. But the cafeteria, each and every table and chair, we made sure that it's actually 6 feet apart. You can sit, there are chairs where you can sit face to face, but you are not sitting next to each other face to face. And also, every day we reinforce about the importance of hand washing. So you wear masks, all the time. Still you get infection. How do you get the infection when you're wearing a mask? If we actually introspect, what do we do? The moment we wear mask, our nose is itchy. Do we make sure that do we hand wash when before touching your nose? No, so what you just itch. So you do not know where did you touch before. You probably touching some surface where a COVID-19 carrier might have touched. There is some virus. So every day we reinforce the employees in every huddle and every email daily. The leadership email will be sent to see that to practice good personal hygiene and hand hygiene measures. So wash your hands and use hand sanitizer or water to wash your hands, and make sure do not touch your face or your nose even though you're wearing masks. So these are some of the protective measures that we take, and any employees, if they suspect that any of the symptoms, they are automatically will be taken off from the work for 10 days. So within that 10 days, they are supposed to call occupational health and they will schedule an appointment for you to test, and you can go through the drive-in testing area, and you should have a negative test to come back. And for the nurses and the nursing aides and the doctors who take care of the immunocompromised patients, like my unit, we actually do bone marrow transplant. So the patients are at high risk compared to anyone else. So if you have a symptom, even if you're negative on the first test, the employee has to get a second test, and that also should be negative to come back to work. So it's automatically, you're not punished from work. If you have a symptoms, you just call the supervisor and OCHAL, you will be taken off from your work schedule for 10 days automatically to reduce the spread among employees. So there were so many resilience when all this started. I would say we all were worried starting in March, even though it started in January, because nobody was that much bothered about here in January and February. But in March, when we see a surge in patients in many parts of the United States, so many nurses were worried, they were anxious, they were angry. But now that's the big, for any disease process or any you have a process of denial and anger always. So now I see most of the nurses, I have friends who work always in the COVID-19 units. So that part is over. Now this is the adjustment part. So now it's everyone's responsibility everywhere. I should say you should not restrict yourself from not going out. So we never had any lockdown. We were fortunate to lead a normal life here, regardless of this disease. But you should know how to take care of yourself. You should know how to maintain your safe distance from every people. You should treat anyone who come across you. You think that, oh, she probably, or he or she probably will have some kind of virus in her body, so I should take care of myself. I should do enough protective measures. That doesn't mean that you should not talk to that person. You can still talk, you can still take care of them, but you should make sure that you should wear the protective measures. The statistics, you're already seeing all the statistics worldwide, and you see that our cases are going high, but that has the different social aspects, which I didn't want to bring it here. So our main goal is that to protect the healthcare workers. And also, if you see, like, you should not wear gloves anywhere in the hospital other than the patient room. So that we actually had that policy in hand, but now it's like at most care, if you see anyone wearing like with gloves in the elevator, they are actually acting as a source of infection. When you're wearing gloves, do you sanitize your hands? No. So that's another mode of spread. So you think that I'm protected because I'm wearing gloves, but instead you're actually transmitting the disease. So the gloves are only worn only in the patient care room. When you come out, you should remove all your personal protective equipments except the mask, and means you should wash your hands, remove all the personal protective PPEs, and wash your hands again. And if your mask you think that contaminated, you should change the mask. Initially, you probably heard it like every day. My parents and my family, and my friends, they call me in March and the beginning of the April. Every day they used to call me because whatever they see in the news is lack of personal protective equipments in United States. So that was actually not real. Yes, so before we were using masks only for 20 minutes, and you don't reuse any masks. Now everyone is using masks. Of course, there is a little bit of lack of supply. So the guidelines are changed based on the pandemic. So still you have enough supplies, but you don't change. So that's a change. That's a change in practice that you usually practice, right? You change the mask in every 20 minutes. Now you're not changing the mask unless it's soiled or if you wear for a few hours. So that was the main change. Other than that, nothing changed here. I think this much only I have to tell. Thank you, Sajid.
Thank you very much, Madam. We are so happy to see you again. I understand the California time is now 4:30 a.m. We should specially acknowledge the pain Madam has taken to get up early in the morning, get ready for the presentation. Thank you so much for joining us. As mentioned by many of the panelists, the containment activities started in many parts of the globe a little delayed. We have a different story. Since we had a Nipah infection 2 years back, our preparedness was a much better one this time. May I request now our chief organizer, the principal of our college, Professor Ponnamma KM, to give the concluding remarks and also to mention some of the most important containment activities that we have done so far. Welcome, ma'am.
Good evening and good morning, everyone. Thank you for being with us for the webinar on IPC, focusing on protection of healthcare workforce in COVID-19. IPC is a scientific approach and practical solution to prevent harm to healthcare providers and patients. It is relevant at every single healthcare encounter. Now, governments and facilities are of the opinion that the final responsibility of the protection is vested with the healthcare provider to train themselves and to take measures to protect themselves from COVID-19. We know that healthcare workforce is the main pillar of any health system in COVID-19 response. Remember the basic principle of infection control. Standard precautions are to be used in providing care to all patients, whether or not all patients are having the infection or symptomatic or not. We must also follow the transmission-based precautions as IPC is everyone's responsibility. Hope these deliberations help you prepare yourself in the fight against pandemic, the worst global public health emergency, as WHO pointed out. Now, I take this opportunity to thank all our distinguished panelists from across the globe. Special thanks to Madam Professor Prasanna Kumari Y, our former Joint Director of Nursing Education. Once again, a big thanks to all our dear participants. Have a nice evening. Thank you very much.
Thank you, ma'am. we especially acknowledge the presence of our Vice Principal, Professor Mary Joseph with us, who is always a motivating force. In February 2020, as we heard that there are a few cases in China, in Madam's leadership, we started organizing the capacity building activities. We had Dr. G. Arun Kumar, Professor and the Director of Manipal Institute of Virology, in a Zoom meeting, interacting with the faculty and postgraduates. After that, a series of capacity building activities were performed to empower clinical nurses, doctors, postgraduates in different aspects of COVID surveillance, containment, and treatment areas. Our postgraduate students are posted in different first-line treatment centers and also actively involved in the activities in airport, railway stations, and also empowering the clinical nurses and supporting them. By this, we have come to the end of today's webinar. We have heard from experts around the globe how to protect the healthcare workforce by adopting infection prevention and control measures. Hope all these sessions were useful to all. I take this opportunity to thank everyone who were with us for this webinar. I thank all the participants for your patient listening and all esteemed panelists for their informative sessions. I also express sincere gratitude towards Professor Prasanna Kumari Y, former JDNE and patron CCRNF. Even though Madam couldn't join us and talk to us from UAE, she was listening to all the presentations due to some technical errors. I also take this opportunity to thank Professor Ponnamma KM, principal of our college, and also the chief organizer of all the webinar and empowerment programs that we conduct. And also Dr. Sridevi J, associate professor, and also the coordinator of this webinar series for providing this platform. I thank Mr. Anish Kumar K and Mr. Salim TK, assistant professors of our College of Nursing, for the leadership in the technical assistance, without which we could not have accomplished this task. All the participants, please fill the feedback form and submit. The link for the feedback form will be open only for 15 more minutes. The certificates will be dispatched the next few days because we have some limitation in sending the certificates. Only 100 certificates can be dispatched per day. So if you have any difficulty accessing the certificates, please mail us in the mail ID given in the brochure. A new feedback form is given in the chat box now. Please see that you are submitting the new feedback form just given in the chat box. Once again, thank you all. Have a nice evening.